Good afternoon. I'm Dr. Aparna Govil Bhasker. I'm a bariatric surgeon and I practice in Mumbai. And as I see my patients in the OPD for consultations, I think one of the major concerns that the patients have, who are those who are suffering from obesity, is that they are very concerned that after bariatric surgery also can they regain the weight back? So in this particular webinar, we are going to understand that whether the weight comes back. If it comes back, what is the reason? And then how can we tackle the weight gain after bariatric surgery? So first and foremost, I think most important thing to understand is that obesity is a chronic progressive disease. So when we talk about diseases, we have certain diseases which fall in the category of chronic diseases. These could be some of the examples of chronic diseases can be like diabetes, like high blood pressure, like heart disease, and obesity also falls into the same category. So when we talk about the definition of a chronic progressive disease, the World Health Organization has, along with all the other scientific societies, now recognized this as a chronic progressive disease, which results from multiple environmental and genetic factors. So when we talk about the causes of obesity, there are environmental factors like we already know about, that sedentary lifestyle, dietary habits, more junk food intake. These are all factors which are basically environmental. But there is also a very strong genetic factor which also leads to obesity. So many a times we see that patients are actually not leading a very unhealthy lifestyle, or they're not eating that much, but despite that they do put on weight. And if we go deeper into the family history, we will see that their parents, siblings, and other members in the family also suffer from the same disease. And how do we define a chronic illness? This is basically defined as a condition that lasts for a year or more and requires ongoing medical attention or limit the activities of daily living. Now, it is very important to pay attention to the statement which says that it requires ongoing medical attention, which means that when we are treating a chronic disease, it is not a one-time treatment process. This process will go on continuously. It is an ongoing process which continues most likely for lifetime. Yes. Now, when we talk about management of obesity as a chronic progressive disease, there are certain terminologies that we as doctors and patients need to understand. There are some terminologies which I think we really need to understand that these need to go away. And one of them is cure. When we talk about a chronic progressive disease, we need to understand that a cure, complete cure, 100% cure may not be possible. And what we're doing is basically managing obesity for life, and we have to battle these kind of diseases on an ongoing process. Failure. This is extremely important because a lot of times patients come to us and they have undergone surgery maybe 3 years back or 4 years back or 10 years back, and they have started gaining some weight back. That does not mean that they have failed therapy. It could also reflect on the seriousness of the disease that they're suffering from. The third important terminology that we have is ideal. There is no ideal treatment or ideal procedure or ideal operation. We need to tailor the treatment as per the patient, gold standard, and then undesirable results. These are terminologies I think which we need to do away with. And the terminologies that we need to really focus on is number one, remission. I will come to that a little bit later. Control. I think what we do in chronic diseases is basically control the disease. So like when we are treating diabetes, we are actually aiming to control the blood sugars. We are not curing diabetes. A person who has diabetes lives with diabetes forever. Same is true for obesity, that when we are advising treatment therapies, we are actually controlling the disease. The third terminology is adjuvant therapy. By adjuvant therapy, we mean that suppose, for example, when we treat a patient with cancer, the patient may need surgery. The patient may need chemotherapy in addition to surgery. They may need radiation therapy in addition to surgery. Sometimes they may even need immunotherapy in addition to surgery. Similarly, when we are treating obesity, we need adjuvant therapy, which could be in terms of say diet and lifestyle modification, or it could be in terms of medical therapy. It could be medicines, medications, or it could be endoscopic therapy. So it depends on what adjuvant therapy may be needed for this patient. We also need to focus on comprehensive treatment. So as we said, that it is a whole gamut of treatment modalities that need to be tried together. It's not a one-time single episode treatment that can cure obesity. Compliance is a very, very important word, because whenever we treat obesity or when we perform bariatric surgery, there is a lot of compliance which is needed from the patient in terms of taking nutritional supplements, in terms of following dietary advice, in terms of following exercise regimens after the surgery, and so on. Compliance to follow-up, compliance to attending support group meetings, because the more compliant a patient is, the better the results get in the long term. Support, I think support is an extremely important word that we all need to understand, because unlike the common perception, I think obesity needs a lot of support from the medical team and from the family for management. And what we also need to consider is 5-year outcomes. So when we are doing bariatric surgeries, when we talk about results of bariatric surgery, I think we need to talk in terms of 5-year outcomes. And last but not the least, I think the other terminology which is very important is recurrence. Because when we talk about chronic progressive diseases, recurrence is something which is known, and that does not indicate that it is failure of therapy, but yes, some diseases are known to recur, and we need to understand how to manage the recurrence of the disease. And medical care, especially when it comes to chronic diseases like management of obesity, it needs to change from unidirectional to bidirectional. So it cannot just be a doctor treating the patient. We need a partnership between the doctor and the patients, and it has to be a joint effort between both. Now, coming on to bariatric and metabolic surgery as a treatment option for obesity, the first thing that we need to understand is that it does not cure obesity. What bariatric surgery does is basically it controls the progression of obesity for months or sometimes even for years. And we have seen that there are patients who've undergone bariatric surgery, and I mean, they have not put on any weight back for many, many years. And there are those who have put on weight back even after 2 or 3 years. Now, at times, patients may experience prolonged remission after surgery, so which means that they may not put on weight after many, many years as well. And but eventually, the obesity may come out of remission, and it may then be called disease progression or recurrence. But it is not at all a failure of therapy. And progression is a sign that treatment may need to be started again, or basically we need to intensify the treatment regimen to get obesity back into remission. So whenever we feel that a patient has undergone bariatric surgery, after 2 or 3 years, you will reach possibly the lowest weight that you would achieve after bariatric surgery. If you start gaining the weight back and the weight increases, say from about, if you've come down to say 65 kilos and you gain about 4 to 5 kgs back within 2 or 3 months, I think that is a time when you need to visit your doctor, and the doctor will then advise you how to intensify your dietary regime, how to intensify your physical activity, whether drugs are required or not. So those things can be tackled at that time. Hence, if you are regaining weight, which is say 4 to 5 kilos after bariatric surgery, I think you need to immediately go and see your doctor and not wait for weight to increase more than that. So how do we define the remission of obesity? How do we define disease progression? How long should the treatment continue? And how do we make treatment choices? So these are some very important questions that we need to address when we are talking about weight regain after bariatric surgery. Remission of obesity. So we don't really have a consensus on this as to what is the perfect result after bariatric surgery. But there are a lot of definitions which are available, and they say that if a person has lost 50% of their initial excess body weight, then it can be considered a remission of obesity. So if we talk about it in normal terminology, it would basically entail that suppose if somebody was 120 kilos and the ideal body weight was about 60 kilos, so they are excess by about 60 kgs. If they lose 30 kgs, then it would be considered that they have achieved a good result. There is another criteria called as Reinhold criteria, in which they say that a person achieves excellent results if their body mass index drops to less than 30. The results are good if the body mass index falls between 30 and 35, and the results are considered to be poor if the body mass index remains above 35 kg per meter square. And there is a third definition, which basically says that weight loss, which induces remission of obesity-related comorbidities and improves the patient's quality of life. This, I think, is a very, very important point, because ultimately, when we are treating the disease, which is obesity, we are basically looking at improvement in patients' quality of life. So it's not only about how much weight the patient is losing, it's also about the life that the patient is gaining. So if the patient's quality of life is improving, there are many patients who are not able to walk, who are not able to climb up steps, who actually get bedridden, or who suffer from uncontrolled diabetes and things like that. So after bariatric surgery, if they are achieving a relief in all those comorbidities, and they can walk without being breathless or without too much pain in their knees and things like that, then also it is considered that the surgery has been successful. There are a few other definitions, like how do we define that this person did not get enough weight loss after surgery? So if a person is losing less than 25% of their excess weight, so this person who was 120 kilos and excess body weight was say 60 kilos, but after surgery the patient has not even lost 15 kg, then we would probably consider that this patient has not lost enough weight. And what about weight regain? How do we define that this person has regained significant amount of weight after surgery? Now, 2 or 3 kilos or 5 kilos, a lot of people gain, but is that something to feel concerned about? So one of the definitions says that if the lowest weight that you achieved after surgery, if you regain about 10 kilos from there, then that would be considered as weight recidivism. Now, we know what to do, but do we know when to do? So this is extremely important, that how much weight, when do we act? Like suppose if a person has achieved the lowest weight loss and then they start gaining weight, what would be the right time to act? And we do have a lot of options, which I will discuss in a while, but most important question to answer is when to act. And for this, normally people would expect that the doctors would have a set algorithm which could be applied and then treatment can be initiated. But unfortunately, obesity is an extremely complex disease, and algorithms can be applied to simple problems, but they are not really suitable for complex decision making, in which multiple choices may be more or less appropriate. So a patient may be able to benefit from just say diet and lifestyle modification, or they may need drug therapy, or probably they may need another surgery. So we don't know. And the available treatment options which are there today for weight regain is, number one, of course, lifestyle modification remains at the base of every therapy that we advise for weight loss. Pharmacotherapy or drug therapy. We have a few options which are there nowadays, and things have become much better than they were before. Endoscopic interventions can be done. And of course, finally, bariatric surgery may need to be converted to another surgery. But before we do anything, we first need to evaluate what is the cause of weight regain. So is there anything which is wrong with the diet? Is the patient able to exercise enough? Or, I mean, if there is no other reason, then why the patient is gaining weight, we need to find that out. Then we need to escalate therapy as per the seriousness or the amount of weight that the patient has gained. Sometimes we may need combination therapies. So we need to also evaluate if the surgery part is proper. Then once the therapy has been introduced, we need to understand when to increase the dosage or decrease the dose. And as I have said earlier, the treatment of morbid obesity is actually lifelong, and it cannot be a one-time thing. Now, step one would always be diet and lifestyle modification and increasing compliance with dietary recommendations. And third thing is pharmacotherapy. So when we talk about dietary recommendations, we actually have a team of dietitians who would go really deep into your dietary call, and they would try and understand if there is anything that can be tweaked in the diet or changed in the diet that would start helping you to lose weight. Because what happens is that over a period of years, the quantity of food that can be taken after bariatric surgery increases. Initially, the food intake is very, very restricted, but gradually the food intake increases. And then what is most important is the quality of food that the patient is taking. If the patient is not taking very good quality of food, if the food is high in sugars, high in fats, then the tendency for the body is to put on weight back. And again, behavior modification has to be checked. If the patient is, whether we need to see whether the patient is grazing on small quantities of food throughout the day, or is there any intake of alcohol, is there any intake of cola drinks, and things like that, junk food. So small things, small portions at a regular intervals can also make a person put on weight. Then the third thing is pharmacotherapy. Now, on the other side of the screen, you can see that there are a few drugs which are listed. There are a few drugs like phentermine, lectopyramide, lorcaserin, naltrexone, and bupropion. So these are the drugs which are now being used for weight loss, for weight regain after bariatric surgery. And a lot of times these drugs actually give us very good results. Unfortunately, in India, we don't have too many of these. Some of these, there are concerns about certain side effects and things like that after intake of these drugs. But what we do use regularly in India at the moment is, one is topiramate, which we can start at lower doses, and then gradually, if the patient is able to tolerate and does not have any side effects, then we increase the dose and we see the weight loss response. The other drug which we use regularly for management of weight regain after bariatric surgery is liraglutide injection. Unfortunately, it only is available as an injectable drug at the moment, and it needs to be taken as a daily injection. But yes, it does give good results, and we've had patients who've been able to lose about 15 to 16 kgs of weight because of this drug. Now, the question that needs to be answered is that which drug needs to be used when? This, of course, your doctor will be able to tell you after evaluating and clinically and deciding what would probably be the best option. So whether it's increase in food intake which is making you gain weight, or whether it is decreased physical activity, or is it increased hunger. So these things need to be evaluated before we actually go into advising drug treatment. Duration of pharmacotherapy. Now, we don't have any set guidelines, but yes, what we do is that we define target weight, which is usually the lowest weight that has been achieved by the patient after bariatric surgery. So suppose if a person was 120 kgs, and after bariatric surgery, they reached 75 kilos. And over a period of years, they gained, say, 10 kilos or 12 kilos and went back to 87. So in my practice, what I do is that target would be to get them back to the lowest weight achieved, which would be, say, 75 kgs. And once the patient loses this 10 or 12 kilos, we start tapering the drug therapy. And then we keep them under a strict follow-up protocol. And we see that after tapering and stopping the drug, if this patient is starting to gain weight again, and that is the time when we may need to reintroduce the drug along with diet and lifestyle modification. So this is what we practice. Of course, we don't have any set guidelines at the moment. The second thing that can be done is endoscopic intervention or revision surgery. So we need to evaluate, number one, is whether the surgical part is all right. Because what happens is that body's tissues are very elastic, and when we do a sleeve gastrectomy or a gastric bypass, everything will eventually dilate and become a little bit bigger. So after a sleeve also, the stomach pouch will tend to dilate to a fair degree, and which is very evident from the fact that initially the patients are able to eat much lesser, but as time passes by, as years go by, patients are able to eat a little bit better. So we need to evaluate the stomach, whether how much has it dilated. So this can be done by using endoscopy and by using barium X-rays, etc. We can see that whether the stomach is really dilated or it's within acceptable limits. Similarly, in the case of gastric bypass, we need to see whether the pouch is dilated or not, or whether the joint where the pouch and the intestines have been attached, if the joint is dilated. So there are certain endoscopic interventions that can be used to probably reduce the opening of the gastric pouch to the intestine, or even with a sleeve gastrectomy, sometimes a replication can be done from inside. So this can again give some degree of weight loss, but there is no guarantee that it will not dilate once again. So again, like everything else, endoscopic intervention may give a relief for some amount of time, but patient may still need to be on drugs, patient may still need to be on diet and lifestyle modification, and the whole combination will actually need to be together to make them lose weight. But yes, anatomical factors need to be considered, and revision surgery would be, I think, one of my last options when I talk about weight regain after bariatric surgery. And this I would probably advise a patient only after trying anything else and it's not working. And we can see that the quality of life of the patient is going down. The other indication would also be re-emergence of comorbidities. Now, a few procedures which we have. So if you see over here, this is a gastric band. Now, we don't see too many patients with this gastric banding procedure because this was very popular about 10 to 15 years back, and a lot of patients
In bariatric surgery, but there are a few standard procedures like gastric banding, sleeve gastrectomy, and gastric bypass. And the options for revision after each of these can vary. So after a gastric band, we could convert it to a sleeve, or we could convert it to a gastric bypass, or to a mini gastric or a one anastomosis gastric bypass as well. Sleeve gastrectomy again can be converted to a whole range of bariatric procedures. And same is the case for Roux-en-Y gastric bypass. Here there could be different reasons, as I had spoken before, that it could be the joint which is dilated, or it could be a candy cane, it could be a fistula between the pouch and the stomach, and there could be other behavioral factors. So we could either increase the restriction by probably reducing the anastomotic size, or we could increase the malabsorption by increasing the length of the reducing the length of the common channel. Now, I think I wouldn't really go into the details of what we do when and all that, which procedure needs conversion to what procedure. I think that would be best done when the patient is with us and we can evaluate them clinically. But the take-home message would be basically that we need to set the right expectations after bariatric surgery. And one of the most important things to understand is that obesity is a chronic progressive disease, and it needs lifelong management. You will need various permutations and combinations even after bariatric surgery to help you to maintain the weight loss. It is a chronic disease and it needs to be treated like one. And what is most important is that it's not that the patients and doctors are failing to treatment. It is the disease that wins. So more severe the disease, more difficult it becomes to treat. And always think about treating the disease early and not wait for it to increase too much so that it becomes difficult to treat. And we obviously don't have any set algorithms, but yes, this is an evolving science and we are all learning every day. But we have best interest of our patients at our heart, and treatment has to be tailor-made. It cannot be that I can advise the same treatment to each and every patient. Once the patient comes, we evaluate clinically and then we advise what needs to be done. Thank you.